Hey everybody, it's Jason here, West Volusia CPR and westvolusiacpr.com, coming to you today with a quick little video discussion on something that's very common in the ICU setting and something that's very necessary for every ICU nurse to understand, and that is arterial blood gases. Let's get started. Hey everybody, welcome back. So today our discussion is on arterial blood gases and how to interpret them in an effort to be able to help identify what's going on with our patient. So to get started, an arterial blood gas is drawn from a radial artery, a brachial artery, or a femoral artery in order to be able to give us a good sample. We need to use this to be able to determine how our lungs are doing, how our kidneys are doing, and how they're working together to keep everything happy. So to start, let's talk about our pH range. So our pH range is 7.35 to 7.45 to make a normal pH range. If it's less than 7.35, then it's going to be acidotic. If it's going to be greater than 7.45, it's alkalotic. Now you can have some causes for that. You can have a respiratory cause, or you can have a metabolic or a renal cause. That's how we look at it. So the respiratory component is carbon dioxide. Carbon dioxide range is 35 to 45 millimeters of mercury partial pressure. So PCO2 is 35 to 45. If it's less than 35, it's acidotic. If it's greater than 35, it's alkalotic. All right, so right here was definitely a long day, and I misspoke. Thank you to Teresa for pointing this out to me. So if your PCO2, partial pressure of carbon dioxide, is less than 35, then you are alkalotic. You're blowing off your carbon dioxide. However, if your PCO2 is greater than 45, you're retaining carbon dioxide, and it is acidotic. Hope that clarifies. Same thing, we have our bicarb. Okay, we have a buffering agent produced by the kidneys that is then interpreted as bicarb, but no, it's not Arm & Hammer baking soda, okay, but we call it bicarb. Its normal range is 22 to 26. If you are less than 22, you are acidotic. If you're greater than 26, you're alkalotic. So notice bicarb is an opposite relationship to carbon dioxide. If carbon dioxide's low, you're blowing off, it is alkalotic. If your bicarb is low, you're not producing, it's acidotic, and vice versa for the other end of the range. Okay, so they work opposite of each other to be able to compensate. And then of course you have your partial pressure of oxygen, which is a partial pressure of 75 to 100, and you have your arterial saturation. The percentage of hemoglobin that is bound with something is your saturation, not your oxygen concentration, and that is 94 to 100% is the general norm. Okay, so let's talk about right quick how to interpret with what we now know. If I look at my blood gas and I'm less than 7.35, I already know I'm acidotic. Now the question is why? I look at my carbon dioxide. If my carbon dioxide is what? Greater than 45, I'm respiratory acidosis. Okay? If my bicarb was low and my carbon dioxide was normal, then I would be metabolic acidosis. Okay? Notice I said what I said. If my bicarb was low and my CO2 was normal, 35 to 45, then I'm in a metabolic acidosis. Let's look at the other way. What if my pH is higher than 7.45? That says alkalotic, and I cannot be judgmental and automatically say it's going to be the kidneys or automatically say it's going to be the carbon dioxide. I have to look. And if my CO2 in alkalosis is less than 35, I'm blowing off my CO2 because my person's agitated, they're in pain, my tidal volumes are too much on my vent, they're panting for whatever reason, then I am in a respiratory alkalosis state. However, if my CO2 is normal and my bicarb is 26, 27, 28, 29, then I'm a metabolic alkalosis. And then you have your compensated states. So you have a person who's been in a condition for some time and their body has had time to adjust from a renal standpoint, or they have an acute change and they immediately kick in a respiratory compensation. So notice what I said. If it's a metabolic correction, it takes time versus a respiratory correction is instant. All right? Just hold your breath long enough and watch what happens. Eventually you, and that's not because your oxygen fell, it's because your carbon dioxide climbed. And so you started breathing faster, right? When you couldn't hold your breath anymore, you started breathing faster to blow off carbon dioxide. So same thing, if I've got a pH of 7.35, 7.36, so I'm in the lower end of normal, and my carbon dioxide is, say, 30 to 35, okay, I'm blowing off my CO2 and my pH is on the lower end of normal. I then look at my kidneys, I look at my metabolic, I look at my bicarb. And if my bicarb is low, suggesting acidosis from the metabolic standpoint, and my pH is on the lower end of normal and my CO2 is low, then the cause of my problem is my metabolic, and I see that my carbon dioxide is blowing off to compensate. Now I should also see an increased respiratory rate. If I'm on a ventilator, I should see increased tidal volumes. If not, I should see deeper breathing pattern. Okay, so that's saying metabolic acidosis, but compensated by the respiratory. Conversely, vice versa, let's look at it. What if my pH is 7.44, 7.45, maybe 7.46, just slightly out of range, and my CO2 is 45, 46, 47, 48, okay, that is a respiratory alkalosis state, because that's a respiratory retention. That's a CO2 retention, which does not create alkalosis. It creates acidosis, but my pH is alkalotic. So again, I have to look back at my metabolic and I'll see my bicarb is high, maybe 30, maybe even 35. And why? Well, probably because my patient's been getting a lot of Bumex, it's been getting a lot of Lasix, they're on a Lasix or Bumex drip. We've been hammering them for days, trying to stimulate the kidneys, trying to get volume off of them. So I have all these metabolic influences on my kidneys, increasing my buffering production because I'm stimulating my kidneys, and it's resulting in a metabolic alkalosis state. That's really the most common one I see in critical care setting, is a metabolic alkalosis from heavy diuretic therapy. And the only way that you can compensate that alkalosis is to not breathe. Of course, we know that's a problem because eventually you won't get enough oxygen, but I've never seen anyone not breathe enough. Okay, so they'll always breathe, so you tend to stay more alkalotic in a metabolic alkalosis. Your respiratory is never going to fully compensate there, but definitely in a metabolic acidosis state, lactic acid, all right, I got a person in sepsis and they're not perfusing well, high dose pressors, whatever's causing me to have lactic acid buildup, I will pant and ventilate off my carbon dioxide in an attempt to compensate. So I hope that gives you a little bit of more clarity and understanding in ABGs. Again, look at your pH, then look at your carbon dioxide, and then look at your metabolic. See if anybody's out of whack, see if anybody's compensating, okay? And then move forward and further assessing your patient, using your eyes, using your ears, using your hands, taking a look, listen, and feel of your patient to be able to correlate their presentation with your lab values. So that being said, that completes our video today. Sure hope you guys get something out of this and it helps you in your clinical practice, helps you in your understanding. Please feel free to share it, talk about it, teach other people by all means. That's what this is all about, is spreading the word and getting everybody up to speed. If you have any other questions, feel free to visit us at our website, westfeluciacpr.com. Feel free to hit me up by email at admin@westfeluciacpr.com. Even my phone, 386-689-8051. We really look forward to hearing from you. We look forward to helping you out. If you have any suggestions, feel free to give us suggestions. We would love to help you guys learn about something that you maybe don't already know, or something you know and you think other people should know about it too, but you don't have the time or want or whatever to make a video yourself, we'll be happy to do it for you. Just give us those suggestions. All right. Otherwise, enjoy your July 4th this year, 2020. Have a great time and stay safe. Bye.